nervous system and endocrine system work together to monitor your body's activity, determine what your body's doing. Okay. The nervous system, okay, is an immediate, short-term response. Whenever you see immediate, you know it's a nervous system. Happens right away, short-term, the body acts to it. The endocrine system is a long-term, general area response. Okay, so very short-term immediate is your nervous system. If you have a long-term response to something, it is your endocrine system. Okay, the endocrine system releases chemicals into the bloodstream called hormones. Okay, these hormones affect the body. They leave a gland or gland-like structure that produce them. They enter into the bloodstream. Okay, they travel through that bloodstream to a target organ or tissue. And then they cause that target organ or tissue to respond, okay, to give a result. So it's like our nervous system. Gets stimulated, travel down the axon to the target organ, made the target organ respond. That was an immediate response. Happens extremely fast. Okay, this one produces into the bloodstream. Hormones go from the pituitary gland, thyroid gland, a suprarenal gland. They'll go into the bloodstream, travel till they get to that organ. Once they're the organ, then they elicit a response. So it's much slower, but it's a much longer acting response. Okay, so the main endocrine organs that we have in our body are the pituitary gland, the hypothalamus, the thyroid gland, the thymus gland, the suprarenal glands, pineal glands, parathyroid glands, pancreas, and your reproductive glands. Those are all the different main endocrine organs. Okay. Other endocrine organs or tissues. Okay. There's also hormones produced by the heart, kidney, adipose cells or fat cells, and your digestive tract. Those are minor ones. Okay. We're going to go through each of these systems. Okay. We're going to do the hypothalamus. The hypothalamus is the production of antidiuretic hormone, oxytocin, and other regulatory hormones. The pituitary gland. Pituitary gland, we have an anterior lobe and a posterior lobe. The anterior lobe produces ACTH, TSH, GH, PRL, FSH, LH, and MSH. Okay. The posterior part of it, the posterior lobe of the pituitary, produces ADH, antidiuretic hormone, and oxytocin. Okay. The thyroid gland. The thyroid gland produces T4, T3, and calcitonin. The suprarenal glands, which used to be called the adrenal glands. Okay, it has a medulla and a cortex. Okay, any organ we talk about could have two divisions. The medulla is always the inside. The cortex is always the outside part. So in the suprarenal glands, there's a medulla, which is the inside region, which produces epinephrine and norepinephrine. We talked about that with the parasympathetic and the sympathetic nervous systems with your fight or flight response. Okay. And then the cortex of the suprarenal glands produces cortisol, corticosteroid, aldosterone, and the androgens. You have the pancreatic islets, which produces insulin and glucagon from your pancreas. You have the pineal gland. Remember, the pineal gland was just distal to the thalamus, the little gland, and that produces melatonin. That controls your circadian rhythm. You have the parathyroid gland. Okay, on the posterior surface of the thyroid gland, produces parathyroid hormone. So behind the thyroid gland, your parathyroid gland. There are four little bumps, which is your parathyroid gland, and they produce PTH. Okay, organs that have secondary endocrine functions like your heart, heart and kidneys. Heart produces atrial, natriuretic peptide, and brain, natriuretic peptide. Okay, that'll be in chapter 21. The thymus, okay, secretes thymosins, and that undergoes atrophy during adulthood. So after puberty, the thymus starts to disintegrate. You have adipose tissue, which secretes leptin and recitin, which controls the breakdown of the adipose tissue for energy needs. Digestive tract secretes numerous hormones also. The kidneys secrete erythropoietin and calcitrol. Erythropoietin controls the production of red blood cells. Okay, and then calcitrol. Gonads, males or testes, They produce androgens like testosterone and inhibin. And the ovaries for females produce estrogen, prostrogens, and inhibin. All right. That's basically the overview of what we're going to be going over the endocrine system. Okay, hormones. Word by Latin means to excite. Okay, there's 4 groups based on the chemical structure. There's amino acid hormones. There's peptide hormones. There's steroid hormones. And there's eicosanoid hormones. Okay, those are from polyunsaturated fats. So you got amino acid, peptide, steroid, and eicosanoid hormones. The amino acid hormones, okay, are structurally similar to amino acids. Thyroid hormones are derived from tyrosine. Epinephrine and norepinephrine are from tyrosine. Okay. Pineal gland, the melatonin, is derived from tryptophan. Tryptophan is a hormone found in turkey. That's why Thanksgiving time, you have a big turkey, you sit down and watch a football game, what do? You fall asleep, right? Turkey has tryptophan in it. Tryptophan gets converted into melatonin. Melatonin tells the body it's nighttime, the body goes to sleep. So you have a big turkey dinner, there's a lot of tryptophan in turkey, and that produces melatonin. That's why you sleep after a big Thanksgiving meal. Okay, so these are the basic structure of amino acids. That's how they're produced. Amino acids have 4 attachments to it. They have an alpha carbon, which is the carbon with my pencil there, which is in the dead center. Okay, they have a hydrogen attached. They have an amino group attached, which means nitrogen. And they have a carboxyl group attached, which is a carboxylic acid. All amino acids have those 3 things. They have this carbon in the center and these 3 things attached, every single amino acid. Okay, and then they have an R group attached. This R group is a side chain. That's what makes each amino acid different. That determines the property of each amino acid, whether it's a 1 carbon, a 2 carbon, a ring, whatever it is, that R group is different. But those 3 groups are all the same for all amino acids. Okay, so this is tyrosine. This is what makes you tired. Again, here's your amino group, here's your H group, here's your carboxyl group, and your alpha carbon. So this here is your R group. Okay, so this is tyrosine. And every amino acid has a 3-letter abbreviation. When you get into biochemistry, these become very important. But this is the R group right here. Okay, this, why didn't that draw? There we go. The CH2, then the benzene ring, then an OH group, phenyl group. Okay, and that's just different in all amino acids. This is tryptophan. Again, here's your nitro group, nitrogen, your carboxylic acid, your hydrogen, your alpha carbon. This is the R group. That's what makes things different. Every amino acid has a different R group. R just stands for organic group. That's all it means. All right, peptide hormones. Those are amino acid hormones. They have similar structure to amino acids. Peptide hormones. These hormones are chains of amino acids. Amino acids link together to form proteins. Okay, every protein in the body, thousands of them, all come from 20 amino acids. The only difference is the order that the amino acids are linked into. And that order is determined by your DNA. The DNA determines the order of amino acids through DNA to messenger RNA, transfer RNA, etc. So all forms from the pituitary gland. So everything produced from the pituitary gland are peptide hormones. Okay, so these are all peptide hormones. Okay. Steroid hormones. They're derived from cholesterol. Cholesterol is a steroid, which means it has it's a 4-ring structure. So all steroids have this basic structure of different rings. There's 2 rings, 3 rings, and your 4th ring. All steroids have these 4 rings that are tied together with different attachments to them. That's what makes a hormone. Okay. Examples of hormones are reproductive hormones, suprarenal cortex hormones, etc. Okay, those are your steroid hormones. And the eicosanoids are like your arachidonic acid, which are your long chain fatty acids. They're acids which have carboxylic acid group at the end, and then they have this long chain. These are all carbon. Every bend is a carbon atom, and this long chain of carbon atoms associated with it. Okay, They're mainly associated with blood clotting because look how long they are. Okay, they're not soluble. They get to an area where you're bleeding and help clot the blood. Prostaglandins, leukotrienes, thromboxans are all examples of eicosanoids. Again, associated with long chain fatty acids associated with blood clotting. All right, so hypothalamus. The hypothalamus controls the pituitary gland. Okay, so you have your hypothalamus. There's the brain. This is your hypothalamus. Hypothalamus is a stalk that comes off of it, and it connects to the pituitary gland. This stalk is called the infundibulum, and this is your pituitary gland, and this is your hypothalamus. Okay, so the hypothalamus sends information down to the pituitary gland and controls the release of the hormones. And it travels with nerves through the infundibulum. Okay. Hypothalamus functions by 3 mechanisms. It secretes regulatory hormones by secreting, releasing hormones and inhibiting hormones. It acts as an endocrine organ, releases antidiuretic hormone and oxytocin to the pituitary gland. And it contains autonomic nervous system centers. So it gives control over the suprarenal medulla. Okay, that's where the norepinephrine is. That's your fight or flight response, your parasympathetic and sympathetic nervous system. Okay, so those control your autonomic nervous system. Those are the 3 mechanisms of control the hypothalamus has. Okay, so here's your hypothalamus. Okay, and the hypothalamus, again, controls the suprarenal glands, norepinephrine and epinephrine. Okay, flight or fight response. It goes through the infundibulum to control the pituitary gland. Okay, so it produces the hormones ADH and oxytocin, regulatory hormones, and adrenal medulla. These are 3 functions of the hypothalamus. Okay. Pituitary gland is also called the hypophysis, another name for it. It attaches to the hypothalamus through the infundibulum. That's the stalk that connects the hypothalamus to the pituitary gland. It sits in the hypophyseal fossa of the sella turcica. Remember we said if it sits down here, the sella turcica of the sphenoid bone goes like that. So the infundibulum comes down, and the pituitary gland sits inside it. This is all bony structure here. Okay, and it encases around it. That's where when brains are removed, the pituitary gland doesn't come with it because it's encased in this bony structure called the sella turcica. Okay, the pituitary gland consists of 2 lobes. There's an anterior lobe, which is the adenohypophyses, your anterior lobe, and your posterior lobe, which is your neurohypophyses. The adenohypophyses releases 7 peptide hormones. Remember, the pituitary gland releases all peptide hormones. The neurohypophyses releases 2 peptide hormones. Okay. Again, this is a sella turcica of the sphenoid bone. Right here, you can see this encasing the pituitary gland. This is your pituitary gland right here. This is the anterior portion. This is the posterior portion. Your adenohypophyses and your I don't think of the name of it. And the posterior, the neurohypophyses, sorry. Okay, so you see your hypothalamus, okay, and that connects through this infundibulum right here. Okay, so you have an adenohypophyses and a neurohypophyses, anterior lobe, posterior lobe. Okay, and we talked about this, hypothalamus and pituitary glands, the different hormones. 7 peptide hormones from the anterior pituitary, the adenohypophyses, and then 2 from the neurohypophyses, the posterior pituitary gland. So we're talking about the pituitary gland. The pituitary gland has 2 divisions, an anterior division and posterior division, or lobes. The anterior lobe is the adenohypophyses. The posterior lobe is the neurohypophyses. The anterior lobe produces 7 peptide hormones. The posterior lobe, the neurohypophyses, produces 2 peptide hormones. Okay, so the neurohypophyses, that's the posterior lobe of the pituitary gland. It's innervated by nerves from the hypothalamus through the infundibulum. The hormones released are called neurosecretions. It releases two peptide hormones. One is ADH, anti-diuretic hormone, and the other is OT, oxytocin. Okay. Antidiuretic hormone is also called vasopressin. Okay. It's released in response to a rise in electrolyte concentrations or a fall in blood pressure. So think about what it does. Antidiuretic, what means it makes you retain water. It's an anti-diuretic, so it prevents water loss. So if you have a high, it makes you more, if you have high electrolytes, you need to dilute it because the concentration of electrolytes is too high in your bloodstream. Okay? So you have to retain water to dilute that. So a rise in electrolyte will cause the release of antidiuretic hormone. A drop in blood pressure, okay, you need to bring it back up. You release antidiuretic hormone. You release more water, you retain more water, the blood vessels become larger because there's more pressure in them, and you increase your blood pressure. Okay? So if you increase the amount of water in the body, your blood pressure goes up. You have a tube, you put more water in the tube, the pressure becomes higher. You keep the tube diameter the same. Okay? So both those things will cause antidiuretic hormone to be released. A rise in electrolyte concentration or a fall in blood pressure. It targets the nephrons of the kidneys, causes the kidneys to retain water to prevent dehydration, constricts the peripheral blood vessels, which elevates blood pressure also. So that's what ADH does, antidiuretic hormone. Oxytocin targets the smooth muscles of the uterus. Okay. Targets the contractile cells of mammary glands, causes contraction of smooth muscle cells of the uterus, results in uterine contractions, right? During delivery. Okay. For the fetus to be born, the uterus has to contract. Oxytocin is one of the hormones that causes contraction of the smooth muscle of the uterus. Okay. Causes the epithelial cells of the mammary glands to release milk from the nipples. Okay. Oxytocin is also active in males, not just in females. Causes smooth muscle contraction in the prostate gland for males. On your nursing exams, on your NCLEX, you will see a question. They're there every year. This is oxytocin has no effect, basically oxytocin has no effect on males because it only causes uterine and mammary gland contractions. And that's not true. Oxytocin causes uterine gland contraction, mammary gland contractions, but in males, it also causes smooth contractions in the prostate gland. So it does function in males also, not just in females. Okay, so here's a summary of it. This is your neurohypophyses, okay? Your antidiuretic hormone, oxytocin, are the two peptide hormones released from the neurohypophyses. Okay, antidiuretic hormone is also called vasopressin, and it targets your kidneys. Results in resorption of water to increase the water supply and elevation of blood volume and blood pressure. Okay. Oxytocin targets uterus and mammary glands in females, causes labor contractions, uterine contractions, and milk ejection. In males, it targets the ductus deferens and the prostate glands. Okay? Contraction of the ductus deferens and prostate, and ejection of secretions. Okay, so oxytocin is active in both males and females. The adenohypophyses, this is your anterior lobe of the pituitary gland. Has three different regions in the anterior lobe. Has a pars distalis, which is where most of the hormones come from, the pars intermedia, which secretes the melanocyte stimulating hormone, and pars tuberalis, which wraps any portion of the infundibulum. Okay, so here's your adenohypophyses, your anterior portion of your pituitary gland. Okay, and this is the pars tuberalis, where most of the hormones are secreted from. This is a pars intermedia, the intermediate portion. And the back portion here, which wraps around the infundibulum, is your pars distalis. Okay. So the adenohypophyse has 5 different cell types for producing different cells. Release thyroid stimulating hormone, TSH, okay, which releases your thyroid hormones. Corticotropins, corticotropes, okay, release ACTH, adrenocorticotropic hormone, and it releases MSH, which is melanocyte stimulating hormone. And I think I froze up again on this. Man, I don't know what causes this to do that, but it sure does it. Let's get that. Let me get this real set right here. See if I can bring this back real quick. Okay. There we go. At least I figured out how to get it back real quick. Okay. And play that. So 5 different, we're right here. 5 different cell types. There's thyrotropes, which, like we said, release thyroid stimulating hormone. Corticotropes release ACTH and MSH, melanocyte stimulating hormone. And the gonadotropes, okay, release follicle stimulating hormone. They release luteinizing hormone in females, which triggers ovulation, development of the corpus luteum, and secretes progesterone. Okay, those are your gonadotropes. And the other 2 are your lactotropes, which release prolactin, and your somatotropes, which release growth hormone, which is called somatotropin. Okay, those are the 5 different types of cells associated with the adenohypophyses, the anterior portion of the pituitary gland. Okay, and here's a summation of the, remember there were 7 different peptide hormones that were released, okay, from the adenohypophyses. Okay. Again, there's thyroid stimulating hormone. Okay, stimulates T3 and T4 from the thyroid glands. Adrenocorticotropic hormone, ACTH, okay, stimulates glucocorticoids and secretions. You have 2 different types of gonadotropins. You have follicle stimulating hormones, which stimulates the release of follicles, and luteinizing hormone, okay, which targets the follicular cells in the ovaries of females and the testes in males, causes ovulation, corpus callosum, and progesterone secretions in females. You have prolactin, okay, targets female mammary glands and causes the production of milk. You have growth hormone, causes growth of cells in the body. And you have melanocyte stimulating hormone, which causes the production of melanocytes for pigmentation in the skin. Okay. Then you have the hypophyseal portal system. Okay. This is the hypothalamus that controls the pituitary gland. So hormones from the adenohypophyses are controlled by hypothalamus secretions as they're attached through the infundibulum. These secretions are distributed to the adenohypophyses by what's called the hypophyseal portal system. Okay, so within the infundibulum, there's a plexus of capillaries. Okay, so you get secretions that leave the primary plexus, and secretions enter into the portal vessels. These secretions arrive at the secondary plexus. Secondary plexus surrounds the 5 types of cells of the adenohypophyses. So that's how it's controlled from the hypothalamus through the hypophyseal portal system into the pituitary gland. And then it goes around the 5 cells that make up the adenohypophyses. Okay. So here's what it looks like. Okay. These are your primary capillaries here, because this is the hypothalamus, that's where it's secreted. Okay, goes down through that, and it secretes around the 5 different types of cells in the adenohypophyses. So this is your adenohypophyses. This is your secondary capillary plexus that goes branches off the primary. You can see the neurohypophyses behind it. That's the posterior one. And these are your endocrine cells. Okay, so coming into it, you have the superior hypophyseal artery, brings blood into the primary capillary plexus. Okay, then you have the portal system with your primary and secondary capillaries. Then you have the inferior hypophyseal artery, delivers blood to the capillary plexus in the neurohypophyses. Okay, so the superior hypophyseal artery delivers blood to the adenohypophyses. The inferior hypophyseal artery delivers blood to the neurohypophyses, the posterior section. Okay, and then these here, the hypophyseal arteries, hypo veins, carry the blood back into the circulatory system of the body. So it goes out through it. So it comes in through the superior and inferior hypophyseal artery, gets distributed throughout the the adenohypophyses and the posterior hypophyses, and then goes out through the hypophyseal veins that carry back into the venous system. That's the hypophyseal portal system. Hormones released by the pars distalis of the adenohypophyses, that's the most anterior section, is your thyroid stimulating hormone, adrenocorticotropic hormone, follicle stimulating hormone, luteinizing hormone, prolactin, and growth hormone. Hormones, that's should be, that's the five there. And then you also got the pars intermedia, which is the melanocyte stimulating hormone. And what thyroid stimulating hormone does, we'll break each one of these down individually now. So TSH, thyroid stimulating hormone, okay, targets the thyroid gland, causes the thyroid gland to release thyroid hormones, calcitonin, thyroxine, and trirothyronine, okay, T3, T4, and calcitonin. Okay, that's released by thyroid stimulating hormone, TSH. Okay. Adrenocorticotropic hormone, ACTH, targets the suprarenal cortex, so the suprarenal gland, okay, for the cortical area, and it causes the suprarenal cortex to release glucocorticoids. These glucocorticoids, okay, I thought it was going to go through there. Okay, so release glucocorticoids into the bloodstream. Okay. Follicle stimulating hormone targets the ovaries of females, causes the maturation of the oocytes, the eggs, and causes the release of estrogen. Targets the seminiferous tubules of males, so it causes sperm production also. So follicle stimulation affects both males and females. Okay, see it there. And luteinizing hormone. Luteinizing hormone targets the ovaries in females, causes ovulation, causes the release of progesterone, which is progesterone, and targets the interstitial cells in males, which releases androgens, which is testosterone, and it causes release of estrogen in females. Okay. So it causes the release of the gonadotropic hormones. That's the luteinizing hormone. Follicle stimulating hormone, and luteinizing hormone are also called your gonadotropins because they cause the release of gonadotropic hormones, testosterone and progesterone. Prolactin, another peptide hormone from the adenohypophyses. It targets the mammary glands, causes the production of milk. Growth hormone. Growth hormone is somatotropin. Okay. This targets cells in the body and skeletal muscles. Causes protein synthesis, which results in growth. Causes lipid mobilization, and causes catabolism. Okay. Breaking down the cells and so you get more energy for the body to grow. Okay. It targets your liver cells. Causes the release of somatomedins, which stimulate synthesis in muscle and cartilage cells. So it basically helps the body to grow, become stronger. That's your growth hormone. And melanocyte stimulating hormone targets the melanocyte cells of the skin, causes the production of melanin to make the epidermis darker. It increases the number of pigments, increases the amount of pigment in the cells. All right, the thyroid gland. Thyroid gland is the anterior surface of the trachea, okay, and slightly inferior to the thyroid cartilage. So it's in front of the trachea, so you can feel it, and it's just below the thyroid cartilage. The thyroid gland you can easily palpitate. You feel the knots, you feel your thyroid gland right below it. Okay, it's very vascular. Okay, it's supplied by the superior thyroid artery, which branches off the external carotid, and it's supplied by the inferior thyroid artery from the thyrocervical trunk. So you got a high vascularization to the thyroid gland, which makes sense. Adrenal, what's the name of the hormonal glands are always going to be highly vascularized because they have to release hormones into the body. Right? So you have a tremendous vascular system in any of those glands. The thyroid gland consists of two lobes, and there's an isthmus that connects the two lobes together. Thyroid follicles, they store thyroid hormones extracellularly, and they release the hormone upon stimulation from TSH, thyroid stimulating hormone. Okay. So here's the trachea. You see the trachea behind here. In front of the trachea, you see the cartilage. Okay. And this is the thyroid gland right here. This is the isthmus that connects the right and left lobes. You see the lobes extending up from both sides. So this is your superior thyroid artery coming down that's going to innervate here. Okay, this is the thyroid cartilage. Okay. You have your right lobe of the thyroid gland. You have your left lobe of the thyroid gland, and your isthmus that connects the two. Okay. And you have your inferior thyroid. Oh, that's the veins. I'm sorry. And the thyroid cervical trunk, which feeds into the inferior thyroid right here. It's just not labeled. Oh, there it is. It's labeled right here. I'm sorry. Inferior thyroid artery. So these two arteries, the superior thyroid artery and the inferior thyroid artery, supply the vascular supply to the thyroid gland. The inferior thyroid veins drain the blood away from it. Okay. The follicles are lined with simple cuboidal epithelium and T thyrocytes, which are follicular cells. Simple cuboid means how many layers? Remember, simple was one layer of cells. Right. Okay, that way secretions of the hormones can occur very easily across into the blood vessels from the cells. So simple cuboid epithelium is what lines the follicles. The follicle cells secrete thyroglobin into the follicles. The T thyrocytes transport iodine into the follicles. Remember, iodine is needed for the thyroid to function. Thyroglobin is made of tyrosine and iodine. Examples of thyroglobulin are T4 and T3. That's secreted in the body to act to help metabolism and to balance the body's states. Okay, T3 and T4 both increase cellular metabolism. So the thyroid gland balances cellular metabolism. These are your thyroid follicles. Okay, and these are the cavities where the thyroid hormones are stored extracellularly. And you can see this is a simple cuboidal epithelium around the thyroid follicles so they can easily secrete into the follicle. Okay, okay, so C thyrocytes are parafollicular cells and they produce calcitonin. Calcitonin regulates the blood calcium by causing reduction in the ion concentration. So it reduces the amount of calcium in the bloodstream. Okay. It targets the osteoclasts of bone. Okay. So it inhibits osteoclast activity. Remember, osteoclasts break down bone to increase the amount of calcium in your bloodstream if it's low. Okay. Calcitonin lowers the level of calcium in the bloodstream. So it inhibits the action of the osteoclast. You don't want to break down your bone and release more calcium. You don't need it. So calcium ions do not leave the bone to enter the blood. So it inhibits osteoclasts, and the nephrons on the kidney, it stimulates the nephrons of the kidneys for calcium ion to secrete calcium ions, to lower the calcium ions concentration in your blood. So it's the calcitonin does two things. It stops the osteoclasts from breaking down your bones to produce more calcium in your blood, and it activates the nephrons in the kidney to remove calcium from the bloodstream and into the urine. Okay, so both those actions help to decrease the amount of calcium in your bloodstream, and that's calcitonin. Okay, so these are the C thyrocytes that produce calcitonin. So how we regulate our thyroid secretion. So decreased concentrations of T3 and T4, okay, triggers the release of thyroid releasing hormone from the hypothalamus. Thyroid releasing hormone targets the adenohypophyses, the anterior portion of the pituitary gland, releases TSH, thyroid stimulating hormone. Thyroid stimulating hormone targets the thyroid gland that triggers the release of T3 and T4, and then normal levels are restored. That's how the cycle repeats itself. So if the decreased amounts of T3 and T4 go to your system, it goes through the steps and increases the amount until they're back up to normal values. Okay, so that's how homeostasis is maintained. So here's your homeostasis is disturbed. So you have a decrease of T3 and T4. Okay. comes into the hypothalamus, releases thyroid releasing hormone, which travels into the anterior pituitary. The anterior pituitary releases thyroid stimulating hormone into the bloodstream, travels to the bloodstream to the thyroid gland. The thyroid gland releases T3 and T4 and brings the liver back up to normal, and homeostasis is returned. It's like a positive feedback loop. Parathyroid glands are behind the thyroid. There's 4 little nodules that sit behind the thyroid. Okay, they're located on the posterior portion of the thyroid gland behind it. They're highly vascularized, like most of our glands for releasing hormones. The superior pair are supplied by the superior thyroid artery. The inferior pair are supplied by the inferior thyroid artery. So there's 2 sets. There's 4 nodules, 2 upper and 2 lower. 2 major types of cells associated with the parathyroid glands are parathyroid cell and oxyphil cells. Okay. Again, so here's your superior thyroid artery as it comes into the top part of the thyroid gland, and your inferior thyroid artery. Okay, as it branches out the thyrocervical trunk and comes up into the thyroid gland. Did I do that right? Yeah, there you go. Okay, these are the parathyroid glands. Okay, 4 little nodules. Sits on the back of the thyroid gland. Okay, those are the parathyroid glands. Okay, you can see the right thyroid gland. You can see the isthmus of the thyroid gland and left thyroid gland. And those little nodules are your right and left parathyroid glands. Okay, and these 2 are supplied by the superior thyroid artery, and these 2 are supplied by the inferior thyroid artery. Okay. Parathyroid glands produce parathyroid hormone. Okay. Parathyroid hormones monitor blood calcium levels, just like the calcitonin did. It increases blood calcium levels. So this works in the exact opposite. So there's your parathyroid glands. Parathyroid glands produce parathyroid hormone. Okay. And parathyroid hormone reduces, they increase your blood calcium levels. Calcitonin decrease blood calcium levels. Parathyroid hormone increase blood calcium. You have to be able to do both for your body to maintain a balance. Okay, so it reduces the urinary excretion of calcium ions. You don't get rid of them, and it stimulates the osteoclast to break down more bone. Okay, so it's calcitrol, which increases intestinal absorption of calcium ions. Okay, so several ways of increasing the amount of calcium in your bloodstream. Okay, the oxyphil cells of parathyroid hormone appear to be immature or inactive parathyroid cells. These are the oxyphil cells with the other ones. Okay, you can see the parathyroid cells and oxyphil cells from the light microscope there. Okay, so parathyroid hormone,
Question.
what it does.
Did you know that there was 4, or is it just the parathyroids? How many are there technically?
There's 4 parathyroid glands, 2 superior, 2 inferior.
All right.
And 2 on each lobe.
Okay. I was just wondering, my mom had hers removed, so I wasn't sure if it was the whole thing or if it was like if there was multiple or just one.
Yeah, there's thyroid gland and a parathyroid glands removed.
It was her parathyroid. It was like huge. She had to have it removed, but I wasn't sure if it was all of them or if it was like, that's why I was asking, is there multiple or is it just one?
Right, there's 4 of them. When they usually do the surgery, it's usually one side that gets affected. So if you use it, but you can remove all 4, but usually it's just the 2 on the infected side where it spreads.
Got it. So now she's got like this little line right here.
Yeah. All right, so this is what parathyroid glands do. Okay, when you release the parathyroid hormone from the parathyroid gland, it targets the osteoclast cells. Okay, it targets osteoclast cells to start to break down bone. Okay, it breaks down bone, removes the calcium, raises the blood calcium level. Okay, so osteoblasts put calcium back into the blood. Okay, causes the kidneys to reduce calcium ion excretion. So as the kidneys maintain calcium by not excreting it. Okay, causes kidneys to produce calcitrol. Okay, calcitrol promotes the small intestine to absorb calcium. Okay, so all those things are acting to increase the blood calcium level when parathyroid hormone is released. The thymus gland. Thymus gland is posterior to the sternum. It's behind the sternum. Okay. It's located in the mediastinal region. Mediastinal means the area between the apices of the lungs. That's your mediastinal region. Okay? That's where the thymus gland is located. It produces thymosin. Thymosin targets lymphocytes, causes lymphocytes to develop into T cells, starts to kick in our immune system. Okay? We'll go through T cells, B cells, NK cells, and all those good things coming up. Okay, so that's the thymus. The thymus actually undergoes atrophy during adulthood, and it secretes thymosins, and it starts to degrade after puberty. The suprarenal glands, okay, those used to be called adrenal glands, same thing, are attached above the kidneys, on the top of the kidneys. These glands are highly vascularized, like all hormone-releasing glands. They're supplied by branches of the renal artery, the inferior phrenic artery, and the middle suprarenal artery. Okay. So here's the suprarenal glands. And again, you have a cortex and a medulla. They produce different hormones. Okay. This is the right suprarenal gland. You have the middle suprarenal artery coming across. You have the right renal artery feeding into it. And that feeds off the abdominal aorta, the main branch right there. And your renal artery, and then the left middle suprarenal artery that feeds into it. The middle and the suprarenal. Okay, so those arteries feed into the suprarenal glands. Okay. The suprarenal cortex, there's two regions of it. Like I said, the cortical region is the outside, medulla is the inside for all organs that have divisions like that. The inside is always in the medulla, outside is going to be the cortex. Okay, so there's your cortex, there's your medulla of the suprarenal gland. Okay, the cortex of the suprarenal gland has three distinct zones. There's the zona glomerulosa, zona fasciculata, and there's the zona reticularis. Okay, so here's the medulla. On the inside, this is your inside here, and then this is the outside going in towards the medulla. So your outer layer is your zona of the cortex, is your zona glomerulosa, your zona fasciculata is underneath that, and your zona reticularis is underneath that, and then you enter into the medulla from there. Okay, so the three distinct regions, the zona glomerulosa, which is the outermost region, produces mineralocorticoids like aldosterone. Okay. The zona fasciculata produces our glucocorticoids like cortisol, cortisone, and corticosterone. The zona reticularis, which is the innermost layer closest to the medulla, it produces small amounts of androgens. So each of those three layers of the cortex secrete different hormones, produce different hormones. So the zona glomerulosa is aldosterone. Aldosterone targets your kidneys, causes retention of sodium ions and water, reducing ions and water loss from the body. So it retains sodium. It pulls sodium out of the urine back into the body. Along with the sodium, it pulls water with it. Okay. So it reduces ions and water loss from the body. So whenever you retain salt, salt helps. You need the water. Salt pulls the water towards it. Okay. So it reduces water loss from the body. That's aldosterone. It increases water retention. Zona fasciculata was cortisol, cortisone, and corticosterone. Those target the liver. They cause the liver to synthesize glucose and glycogen. They start to produce compounds we can use for energy. So cortisol, cortisone, corticosterone causes increase in glucose and glycogen from the liver. Okay. Cortisone, all heard of cortisone shots. Okay. Cortisone shots are injections that help relieve pain and inflammation in a specific area of the body. It was commonly injected directly into the joint. So if you have an infection or an inflammation in your elbow, inflammation in your knee, they inject the cortisone directly into the infected joint. Okay. Even the small joints in your hands and feet might benefit from cortisone shots. Okay, there's problems though. Repeated cortisone shots may cause the cartilage in the joint to deteriorate from the constant injections. So they usually limit the number of cortisone shots that you give into a joint. They'll limit that number. You shouldn't usually get more than every 6 weeks and usually not more than 3 or 4 times a year cortisone injections into the same joint due to the damage of the cartilage in that joint. Okay. Complications of cortisone shots include joint infection. Whenever you give an injection, you always have a chance of infection. Nerve damage. Remember, you're injecting a needle directly into a joint, you can hit a nerve. Thinning of skin and soft tissue around the injection sites. Okay. Temporary flare pain and inflammation in the joint. Tendon weakening or rupture. Okay. Again, you're causing that inflammation to go away, and you're going to start using that joint more and more, but you're not going to feel the damage you're doing to it because you don't feel the pain anymore. Okay. So you're going to continue to damage it, and that can tear or weaken your tendon. You got thinning of nearby bone, osteoporosis from the injection site. Whitening or lightening of the skin around the injection site. Death of nearby bone, osteonecrosis. Okay. And temporary increase in blood sugar are all complications of cortisone shots that can occur. Okay. The zona reticularis, which is the zone closest to the medulla. This targets general cells, causes increase in small amounts of androgens, which is testosterone, and causes the development of pubic hair. That's your zona reticularis. There's a condition called androgen insensitivity syndrome. Okay, it's when a person who's genetically male has an X and Y chromosome is resistant to the male hormone testosterone, your androgen. So as a result, the person has some or all the physical traits of a woman, but genetic makeup of a man. Now this is not, I don't want to say it's common, but it's not really uncommon. I think it's 1 like 11,000 births. And I mean, I know I'm going to age myself here, but how many people have teenage daughters? I mean, that are grown up. You know, we have a teenage daughter, they go through a lot of hormone changes and a lot of problems, and there's a whole lot else. But these people do not know this. And if they only find out about this when they don't get a period. So they may be 13, 14, 15, 16 years old before they're found out, and they go to the doctor and they're told they're a male.
I was actually watching something on TV and there was a case like this.
Yeah. Lately, there's been a lot of episodes of people doing cases like this. It's very interesting what they do. But the psychological component is tremendous here. I mean, with my teenage daughter, if I had to tell her she was a male, we'd have all kinds of problems. Okay. But it is only found that. And a lot of people don't know it till they get married and they go to have a child and they can't get pregnant, obviously, because they're male. And they go to a fertility specialist and he looks at the wife and he tells them that she's a male. She's XY chromosomes. Okay.
So like you wouldn't know until you go to the doctor?
Right. You would know. You'd have no way of knowing. If you just never got your period and you just didn't worry about it, you got married, you went to the fertility specialist, the guy says, you're a male. Then you got to tell your husband that. It's a really strange disease because of the psychological impact it can have. Okay? It's caused by genetic defect on the X chromosome or the female chromosomes. The defect makes the body unable to respond to the hormone that produces melatonin. So you produce testosterone, just like a male, because you're XY, you produce testosterone, but your body doesn't respond to it. It's not sensitive to it. So even though you're producing it, and you're a male producing the testosterone, your body doesn't respond. And if it doesn't respond, then it develops as a female because it's not developing the external secondary sexual characteristics. Okay? It's fine. There's 2 categories. There's complete AIS and incomplete AIS. Complete androgen sensitivity prevents the penis and other male body parts from forming. So you develop and you form as a female, even though you're completely a male inside. Okay. At birth, the child looks like a girl, just normal female. The complete form of syndrome occurs at 1 in 20,000. Oh, I thought it was 1 in 11. Oh, okay. 1 in 20,000 live births. In the United States, there's 4 million births a year. So we basically 11,000 births per day are androgen insensitivity syndrome. So I don't want to say it's common, but it's not that uncommon. And like Ian was saying, there's been a lot of documentaries on this lately. There've been a lot of shows that have dealt with this. My wife watched this Netflix series of midwives, and they dealt with the syndrome. And it's very interesting how they handled it. And there's a lot of it coming out right now, and with all the movements and everything, and how people are handling this type of situation. And it's something that needs to be considered. But you've got to give it the choice of whether to become a male or female at that point, and they can choose what they want to become. And it's an interesting, like I said, it's a psychological dilemma, for a better word for it. That'd be a tough choice at that age to try to figure that out. So a person with complete AS appears to be female, but has no uterus. Very little armpit and pubic hair. That way they can't get pregnant, they're male. At puberty, female sexual characteristics such as breasts start to develop. So they start to develop breasts, even though they're male. Okay. However, the person does not menstruate, and they cannot become fertile. So it's an interesting disease. It's something worth thinking about.
Now, do they have testes inside as well, like where their ovaries would be, or would it be? How would
some do, some don't? It depends on the condition. If it's a complete and the body completed, then the testes are resorbed.
Okay.
But if it's not, then the testes are just underneath and don't descend. Okay. So complete AS is rarely discovered during childhood because there'd be no reason to discover it. You don't need genetically testing on your children. Sometimes the growth is felt in the abdomen or growth that turns out to be a testicle with explored surgery. Like I said, if it's not complete, the testes don't absorb completely and they'll find one. Most people with this condition are not diagnosed until they do not get a menstrual period or they have trouble getting pregnant. That's when you diagnose this. When they don't get their menstrual period, so they go to the doctor and they try to figure what's going on. They find out you don't have a uterus. Okay, or they try to get pregnant. They say, don't have a uterus, you can't get pregnant. But it's become a very talked about disease lately with a lot of TV documentaries. Like you were saying, it's become very interesting. It's been brought to the front a lot more than before with this condition. Types of treatment, estrogen replacement is prescribed after puberty, okay, to keep the female body parts. And treatment as gender assignment can be a very complex issue, and you target for each individual. Basically, the person's going to choose what sex they want to be, and they have to do treatment to go towards that goal. All right, now the medulla of the suprarenal glands. That was the cortex with the 3 different layers. Now we have the medulla. The medulla is the inside layer, and there's 2 cell types. Remember, it says epinephrine and norepinephrine from your fight or flight response. One cell type produces epinephrine, the other produces norepinephrine. Right? That's the medulla. So the medulla of the suprarenal glands produce epinephrine and norepinephrine. Again, there's your cortex, which is the outer layer. Medulla is the inner layer. Oh, did I lock up again? No, I didn't. Okay, we still got it. The hormones of the suprarenal medulla, epinephrine and norepinephrine. Epinephrine and norepinephrine target most cells. Okay, there are fight or flight response, our sympathetic nervous system, cause an increase in cardiac activity. The heart pumps stronger and it pumps more often. Cause an increase in blood pressure because you're pumping more blood in your vessels. You got a certain size vessel, you put more blood into that vessel, it's going to increase the pressure. Okay, increase in glycogen breakdown. Your body needs energy. Okay? It's going to start breaking down glycogen into glucose so we can get energy. An increase in muscular strength and endurance. You're going to work out, you're going to go harder. You must become stronger and longer because there's more energy going to them, more energy going to your muscles during the fight or flight response. Okay. So when our fight or flight response is activated, sequences of nerve firing occurs and chemicals like adrenaline, noradrenaline, norepinephrine, okay, adrenaline's epinephrine, and noradrenaline's norepinephrine, and cortisol are released into the bloodstream. Patterns of the nerve firing chemicals cause our body to undergo a series of dramatic changes. Respiratory rate increases. Okay, you start breathing faster. Blood is shunted away from your digestive tract and directed into the muscles and limbs, which can require extra energy and fuel for running or fighting. Your fight or flight response right there. Okay, your pupils dilate. Again, this is the sympathetic nervous system causing this. The release of epinephrine, norepinephrine into your bloodstream. Pupils dilate. That way you can focus farther away. Okay, that way you can see threats coming from a longer distance off. Your awareness intensifies. Your sight sharpens. Your impulses quicken. Perception of pain diminishes. If you're in an emergency situation, okay, and you're in the middle of fighting or running for your life, and you brush around and get a cut or something, you are not going to notice it. It's not going to be painful until you stop and your body starts to come back to normal homeostasis. So your perception of pain diminishes. Okay, so when you're fighting a person, that's on we used to like PCP or drugs that increase your metabolism, increase this fight or flight response, they're not going to feel pain. Your immune system mobilizes with increased activation. Okay, you become prepared physically and psychologically to either fight or flight, and you scan your environment and looking for an enemy. That's your sympathetic response. That's the fight or flight response. That's what epinephrine and norepinephrine do to our cells. Endocrine functions of kidneys and the heart. These are the ones that are minor or secondary adrenal secondary hormone production. So the kidneys produce 3 different types of hormones also. Okay, they produce renin, which is an enzyme. They produce erythropoietin, which is a hormone, and they produce calcitrol. Okay, the heart produces 2. The heart produces atrial natriuretic peptide and brain natriuretic peptide. Okay, we went over those to that slide. Okay, so the kidneys respond to low blood pressure. So if you have low blood pressure, you've got to increase the amount of fluid in the bloodstream to increase your pressure. So kidneys release renin, and they release that into the bloodstream. Okay, renin converts angiotensin to angiotensin 1. Angiotensin is produced by the liver. Angiotensin 1 goes to angiotensin 2. Okay? An enzyme from the lungs causes a conversion. The enzyme is called angiotensin converting enzyme, ACE enzyme. Angiotensin 2 causes the suprarenal cortex to release aldosterone. Aldosterone causes the increase of sodium, absorbs sodium, which absorbs more water, puts more water back into your bloodstream, causes blood volume to increase, causes blood pressure to go back up. That's how renin works. That's released by the kidneys. Okay. Angiotensin 2 stimulates the release of aldosterone, which is from the suprarenal cortex. Aldosterone causes the kidney to put sodium ions and water back into the bloodstream, and that raises your blood pressure back to homeostatic conditions. Okay. Angiotensin 2 also causes blood vessel constrictions. So if the pipe that the water's in becomes smaller, what happens to the pressure? It goes up, right? Surface area decreases, pressure goes up. So it also causes blood vessel constriction of the smooth muscle around blood vessels, which causes an increase in blood pressure also. So those two things cause renin goes to angiotensin 1, angiotensin 2, aldosterone, sodium and water come back into the blood vessels. The amount of volume becomes larger, which increases blood pressure, and the size of the pipe, the blood vessel constricts, and it becomes smaller. Both those effects act to increase your blood pressure back to normal levels if it drops. And there was a study done on salt retention in the diet, and a lot of both what the study basically says is for a healthy individual, salt's not going to make a very large difference in hypertension. For a person that has hypertension and it is not controlled, salt can affect hypertension and make it worse. Okay, so if you already have hypertension, you can read through the different effects of that. If you already have hypertension, you want a low salt diet. If you're a healthy individual, you do not have hypertension. I mean, low salt diets are good for other reasons also, but it is not going to, high salt, it's not going to affect your blood pressure, okay, unless you have hypertension to start with. Kidneys, parathyroid hormone targets the kidneys. We talked about that. Kidneys can release calcitrol. So kidneys release calcitrol. Calcitrol causes the small intestine to absorb calcium back into the bloodstream. So it increases your calcium levels. Okay? So it releases calcium from the kidneys, so it increases your calcium levels. Right? A production of calcitrol, we produce calciferol is vitamin D. That's how we produce calcitrol. The original precursor comes from cholecalciferol. That's vitamin D. We get that from skin, exposure to sunlight, and our diet. Cholecalciferol is converted to immediate products and intermediate products in the liver. The liver products are converted into calcitrol. Okay, in the kidneys, calcitrol, that's the active form of vitamin D in the body. Okay, so cholecalciferol is your vitamin D. That's your supplement, or you get it from your diet. This exposure to sunlight causes conversion of it into cholecalciferol. Cholecalciferol goes through several intermediate steps to produce calcitrol. So calcitriol, okay, is the active form of vitamin D, the biologically active form of it. Okay, the heart has those two peptide hormones. Okay, so high blood pressure is due to high volume. A lot of times, the heart cells in the right atrium. We haven't talked about the right and left atriums yet, but we will. Okay, so the heart are detected by the right atrium, detected by high volume, increase in the amount of blood in the right atrium. So we have atrial natriuretic peptide and brain natriuretic peptide. Okay, these hormones inhibit ADH and aldosterone. Remember, antidiuretic and aldosterone cause an increase in blood pressure. Okay, remember, antidiuretic hormones, you keep water in. Okay, so the ANP and BNP, those cause a decrease in blood pressure, a loss of, decrease in blood pressure. So it's backwards. Result is your loss of water and sodium ions. So you lose water to decrease the amount or volume of blood in your vessels, which decreases your blood pressure until blood pressure and volume return to homeostatic conditions. Okay, so that's the effect of ANP and BNP, to decrease blood pressure. Okay, by letting water and sodium out through the urinary system. Pancreas. Pancreas is our insulin and glucagon system. Has both endocrine and exocrine functions. Okay, the endocrine functions consist of your pancreatic islets. These control your alpha cells, your beta cells, delta cells, and F cells. These produce your hormones. The exocrine functions produce digestive enzymes. So the pancreas does two things. Produces digestive enzymes, which is your exocrine function. Exocrine means excreting out into the lumen. Endocrine means secreting within into your blood vessels. Okay, so it has both functions. Okay. The endocrine function, it's highly vascularized, like all of our organs that release hormones, has fenestrated capillaries. Fenestrated means there's holes in the capillary wall. There's small holes which allow things to pass easily. That's what fenestrated means. It's supplied by the pancreatic duodenal arteries, and it's supplied by the pancreatic arteries. Pancreas is about 20 to 25 centimeters long. The large round end connects to the duodenum of your small intestine and produces your digestive enzymes. The pointed tail extends towards the spleen. Okay, so here's your pancreas. This is the body of the pancreas and the tail. This is the spleen over here. Okay, and these are the ducts. This goes into the duodenum of the small intestine. And it has a common bile duct up in here that runs through the pancreas, goes into your gallbladder. Okay. So hormones of the pancreas, the endocrine function produces two hormones. Produces glucagon and insulin, both very important hormones in the functioning of blood sugars. Okay. Glucagon comes from the alpha cells. Insulin comes from the beta cells. Glucagon stimulates the liver to break down glycogen to form glucose. So glucagon increases the blood sugar. Stimulates the liver to put glucose into the bloodstream, raises your blood glucose level. Insulin is the exact opposite. These are the yin and the yang. If you do one thing, you gotta be able to do the other too. You gotta be able to shut it down. Insulin increases the rate of glucose absorption by the cells in your body. So it lowers your blood glucose levels. Right? So glucagon raises blood sugar levels, insulin lowers blood sugar levels. Okay. Pancreas, also, the hormones of the pancreas, you also have somatostatin in there besides glucagon and insulin. Okay, somatostatin, okay, those inhibits production of glucagon, inhibits production of insulin. It shuts down both insulin and glucagon production. So it slows the rate of absorption along the intestine, all this resulting in inhibiting growth. Okay, so this slows your body growth down. Remember, somatotropin was your growth hormone that increased your body mass, increases your body growth rate. Somatostatin slows your growth rate down. It decreases both glucagon and insulin production. And you have pancreatic polypeptide from the F cells. Okay? Those inhibit gallbladder contraction and helps to regulate production of some of your pancreatic enzymes. Okay? You can see the alpha cells. You can see the beta cell, which are glucagon, the beta cells, which are insulin cells, the F cells, which are pancreatic polypeptides, and your delta cells, which is your somatostatin. Okay, again, same thing. Alpha cells and beta cells of the pancreas. All right, reproductive hormones. We have the testes. Okay. Interstitial cells release testosterone. This promotes the production of sperm. Maintains the secretory glands. They influence secondary sexual characteristics and stimulates muscle growth. Okay? This testosterone is being produced. Like we talked about with the AIS syndrome, as long as the cells respond to it, these are the effects of it. You can produce all the testosterone you want, but if the cells lack the receptors or the receptors are defective genetically and don't respond to testosterone, you're not going to get any of these processes occurring. Okay? Even though testosterone is being produced. Okay? So the sustentacular cells release inhibin. Okay? Inhibin depresses the secretion of follicle-stimulating hormone. Okay? Inhibin and follicle-stimulating interact to maintain sperm production at normal levels. So the inhibin reacts with the follicle-stimulating hormone to help maintain your normal levels of sperm development and production. Okay, that was a picture there. Ovaries for the females. Oocytes begin to develop in follicles. Oocytes mature due to follicle-stimulating hormone. So the eggs don't mature until follicle-stimulating hormone is present. Follicular cells produce estradiol. Okay. Mature eggs are ovulated due to luteinizing hormone. After ovulation, the follicles become a corpus luteum. The corpus luteum is progesterone. Okay. And the corpus luteum releases relaxin. Progesterone helps get the body ready for implantation of the fertilized oocyte, and relaxin affects the uterine walls, the cells, for the tissue, for the eggs to be implanted into that layer of the uterus. Okay, so progesterone. Progesterone is released after the oocyte is released, the corpus luteum. It prepares the body for pregnancy. That's what progesterone does. It's a steroid that prepares the body for pregnancy. It targets the endometrial lining. The endometrial lining is the inner lining of the uterus. It causes a thickening of the lining to provide a place for implantation of the fertilized egg. So it gets a place ready for that fertilized eggs to bond to. Progesterone targets the mammary tissues, okay, help get milk secretion started, and cause the mammary tissue to prepare for secretory functions for milk. That's what progesterone does. Relaxin works with progesterone to prepare the body for the pregnancy. It starts to loosen the pubic symphysis. Pubic symphysis is the opening to the birth canal, and it loosens that cartilage layer so that can expand when the baby comes down the birth canal. Relaxes the cervical muscles as the baby develops, and also stimulates mammary gland development for production of milk. The pineal gland. Remember, the pineal gland is behind the thalamus, the small little P-shaped gland that you see. Okay? And it produces melatonin. Don't get called melatonin, produces melatonin, your circadian rhythm. Okay? It's part of what's called the epithalamus, which is on top of the thalamus. It contains neurons, glial cells, and special secretory cells called pineocytes. The pineocytes synthesize melatonin. Melatonin slows the maturation of sperm, oocytes, and reproductive organs. It slows everything down, which kind of gets your body relaxed. Production rate rises at night and declines during the day. Okay. So these are the pineal sites. You can see this is the location of the pineal gland, right behind the thalamus. Okay. As you age, everything changes. As you age, exhibits relatively few changes with advancing age, but you can expect changes in reproductive hormone levels at puberty. Decline the concentration of reproductive hormones at menopause in women.